Okay, so let's get started. Richard asked me to speak about leadership. It's rather a broad subject, so I decided I'd simply do what I do as part of the day job. And that's to understand where we've been, where we think that we're going to be going, and also to horizon scan what changes or developments there are which will change the current healthcare landscape. Once we understood where we've been and where we believe we may be going, then we need to decide how we're going to get there and what workforce requirements will be to make that happen. That's where the leadership comes in. Essentially, in designing the requirements for the workforce of the future, form follows function. So let's see where we've been. Let's reflect for a moment on this note to patients from 1978. Not for what it says about the treatment, but for what it says about the prevailing attitude to patient care at that time. Great technical advances, but actually a poor patient experience. Services were technically and clinically focused, as you can see from the rather Orwellian coldness of the patient advice leaflet here for patients undergoing radiotherapy in Birmingham in 1978. This was the patient leaflet that was given to my gran, who had been diagnosed with advanced breast cancer. It was a bit of a surprise to us all, not least to my gran. Lack of patient focus and compassion rather slapped me in the face as a second-year student radiographer. Still does. My gran was frightened, she was emotional, very distressed, and we definitely reported back before the due date. Had a big effect on me, and that stayed with me for the next 40 years of my career. It shaped my approach to patient care. It also shaped my approach to service delivery and also my approach to workforce development. I never wanted that to happen to any of my or anybody else's family, but actually this was very well-meaning and people were doing their best at the time. Patient experience just didn't really feature. So, I developed the mummy test, and this was back in 1980s when I became a clinical tutor for a period of time, and realised that many students had no experience of the emotional distress and anxiety felt by people who fear an adverse outcome, or indeed may have an adverse outcome. The mummy test, put simply, asked them to imagine each patient like their mum or significant other, and ensure that the examination and the experience was at the best it could be. Many other people did something similar. I wasn't the only one, and indeed it's pleasing to see that CQC have adopted the mum test. It's a great way to deliver patient care, and I'm pleased to report that the mummy test is alive and well in Derby and soon to be Burton hospitals. So, where are we going in the 21st century healthcare? I spent a lot of time in the steamship. I'm quite excited that we're on our journey to the space rocket. We're in a changing healthcare landscape, from competition to 5-year forward view. So I'm going to talk about that for a while. It's part of the horizon scan. What's it like currently? Well, it's like this. This is the Lansley reforms. This was the purchaser-provider split that introduced any qualified provider and competition. Complex, isn't it? Would you really design this? If you were designing healthcare from scratch, would you really do this? However, we are where we are. It doesn't work very well. Duplication of service, nobody shares, lack of flexibility, layers of bureaucracy, Focus on finance is just not working very well. So somebody at NHS Central realised that there's a bit of a problem with this. It's going a bit pear-shaped, we can't afford it, and so along comes the 5-year forward view as the precursor to change. It's all about personalised, patient-focused pathways. It describes a very different way of working to deliver an integrated care model. This means that patients are supported along pathways across primary, secondary and tertiary care. In addition to the joining up of the other public sector organisations such as social care agencies, the police, local authorities, and it intends to deliver a better designed joined up experience for all of us. There are several test beds happening across England at the moment, and it's anticipated this will be the new way of working to deliver a healthcare service fit for the 21st century. So at the moment in imaging and in oncology it feels like this. It's really busy, there's a lot more of it, there's an increasing rate of change, and actually in terms of the service delivery model, the advent of the 5-year forward view means that we're doing stuff a bit faster and we're doing more of it. So, what of the future landscape? Well, the future NHS will be focused on integration of care and of services. Medicine will be personalised. Let's not forget that we're not the only people experiencing the changing landscape. The patient of today is not the same as the patients of previous decades. The Google generation are generally well informed, have higher expectations of compassion, quality, speed and efficiency when it comes to their healthcare. We've heard a lot this week about the NHSI app that's allowing us to be able to book online from our phones our appointments within our GP service. We can get repeat prescriptions, and indeed we're also going to be able to have direct access to our medical records. So we're starting to get there. In terms of the patient as consumer, more patient choice, better informed, and let's not forget those joined up appointments, really important. So, what will this new landscape actually look like? Well, there'll be a focus on personalised medicine. The political will to integrate health and social care combined with the change in how healthcare is funded will deliver a different type of structure. This will be technologically enabled, and the tech is really important. Patient pathways will cross boundaries and will be run by multidisciplinary teams. We'll be inhabiting that place in the middle between primary, acute and tertiary care to form a network of provision, and it sort of looks like this. So this slide is courtesy of Dr. Pat Oakley. You can see her logo up in the top corner there on the right-hand side. She's a workforce research fellow for NHS policy and a very useful person to be able to pick up the phone to and say, what's happening? Please tell me what's happening so we can plan the workforce. Anyway, she gave me this slide so I could share this with you. It sort of describes what this place in the middle looks like. It's care where you live. So it's care where you are. We're sort of over here somewhere. Care on the high street, at school, at work, in the supermarket. Essentially, care will be delivered across a wider form than we have now. Hospitals will have porous walls. That's really important. A lot of stuff is going to happen outside those hospital walls. You'll only go to hospital for the difficult stuff, really, that can't be delivered out there. Planned care and rehab will be joined up, nirvana, and it'll be self-help networks and a strong focus on prevention and well-being. End-of-life services will feature in the community setting, and more will be integrated with social care and other public sector agencies. As you can see from the previous slide, we're looking at a very different healthcare landscape. Care is patient-focused and holistic. The welfare needs of the patient will be addressed as part of the care package by a multi-agency system within an STP landscape. Diagnosis will be delivered at scale and at fast pace to deliver a better therapeutic patient outcome. There's talk about investment of $6 billion in developing and providing what they call asset class community care centres, which will be rolled out across the country. There's one of these in Wimbledon, in London, called the Nelson Centre, whereby standard outpatient care can be delivered. Currently, this is open 18 hours a day. Care close to home where you need it, when you need it. Services will be described by the metrics within the model hospital, and will be encouraged to use those metrics to understand how we can better deliver our care by learning from each other. So what does this look like in policy terms? We'll have commissioning, but this is driven via an STP to give a matrix of care linked to health and social care. And we can plan this regionally and nationally. Stuff will be joined up. Dare I say this resembles the old strategic health authorities? However, you can see that the positioning of the regulators, CQC, and also NHSI here, is quite interesting, that the juxtaposition. Their remit is to drive the required improvements with the focus on quality and also on finance. The model hospital, get to know this, really important, measure how your service is doing and see how you're doing in relation to others. These are metrics to measure and compare everybody, so you'll be able to see how you do. The emphasis is on self-improvement and getting it right first time. I wonder at what stage will patients groups be able to get access to this. So I think that we need to make sure that the data is accurate. Data is all. Proactive medicine. Emphasis will be on prevention rather than on cure. More screening, more research, and of course much more demand, thinking about that skyrocket. So in terms of the future landscape, what sort of technology can we anticipate? You've seen a lot here if you've walked around the stands, certainly in the exhibition halls. What type of impact might it have? NHS Digital is right up there in terms of enabling this new platform for healthcare. Hospital walls, as I said, will be porous, and we can be technologically enabled to provide care across a range of locations outside the traditional hospital building setting. IT can support telemedicine, virtual clinics, image transfer and storage, full interoperability, delivery on the high street, delivery at home. Networked. We already have some systems with advanced capability across regions. So there's a joined up RIS-PAC system here in the Wirral, and similarly there's one in the east of England where I work, MRAD. IT allows delivery of healthcare everywhere. So get your breast screening at Boots maybe. It's not beyond the bounds of possibility, and you can collect your Boots points at the same time. Delivery of diagnostics and point of care testing at home. So we have to understand that the systems will look quite different to the traditional model we're working with today. I mean, so for example, I've got one of these Fitbits on here, and it monitors my heart rate, it monitors the lack of sleep I get at night, and it also tells me how many steps I've got. But, you know, it would be quite easy to GPS enable this, and also to be able to get it linked to the emergency services, so that should at some point my heart have a cardiac moment, then they can actually send the services to me. And I think that that's going to be the way of the future. Possibilities are endless, really. Genomics. Well, we may become a monitoring culture whereby the power of genomics allows us to understand and identify our predisposition towards certain diseases. This may lead to repeat diagnostics to monitor those disease markers as follow-up for years. So if you think you've got screening programs now, it's coming, big style, I believe. Diagnostic screening will be on the rise. We've seen this already with an influx of the worried well post-DNA testing from 23andMe and Ancestry, where you can do your mouth swab and you get a readout and you trot to the GP pretty quickly because it tells you might have something nasty. Increased referrals to and from geneticists, we're already starting to see that. So we'll see more scanning from an early age with the emphasis on, as I say, early intervention. The Genome Project has opened up large NHS data lakes where our data is stored together with disease history and outcomes. these large data lakes are used for research and to benefit healthcare in the future. And I'm sure those giant pharma companies will be really interested to get their hands on that data. There are some giant technology companies such as Google, DeepMind, and Amazon who have the computing power and software know-how in order to be able to explore and exploit these databases. Indeed, some of them are already working with NHS partners to provide information research and to move towards better predictive analytic solutions in AI. DeepMind are working with Moorfields Eye Hospital at the moment in order to develop better research into macular degeneration by sifting through the data that's contained in the data lakes and also looking at the digital retinal scans and the patient outcomes. So it's starting to happen. Currently, Google DeepMind are working with NHS partners on an app which performs an echocardiogram in either 2 or 3D when the phone device upon which it sits is placed on your chest. This is linked to an inbuilt predictive analytics platform that provides an instant result graded in either immediate response required, urgent, elective, or indigestion. And it really helps us stratify people. But that type of thing is happening. It's coming to the UK from the USA and may be trialled at the Queen's Square in London early next year. So, artificial intelligence, stroke reporting app. This has already been FDA approved, and you can get the results of your CT scan in 6 minutes. We are living in the future. It's interesting to note that AI reporting is seen as an enhanced diagnostic tool which will assist in bulk reporting and stratifying the positives for human review. So essentially, the machines may ease the burden of high volume reporting. They may also create the reporting capacity required for the upfront diagnostics needed for those large volumes of diagnostic screening activity that we're sort of anticipating. The machines may ease the burden. Think automatic film developers in the 1970s, that was a marvellous thing, dishwashers and also autopilots. They will allow for required service expansion to meet this burgeoning clinical need. Intelligent scanners and imaging machines will allow for greater diversity of workforce, greater skill mix and a redesign of how we work and how we're able to deliver care across many different platforms. The workforce teams we are probably going to need will be more assistant practitioners, I would imagine, and we're also going to make sure that we need to have more advanced practice rather than less, because we're going to be scanning a lot more patients and seeing a lot more people, and so we're going to really need that blend of reporters, radiologists, radiographers and others. What of the far future? Well, this is rather interesting. So could be we're living in a matrix world. What about 10 to 15 years' time? Look at the two slides that we've got here. So the one on the left here is a CT, and then the one on the right is a machine image binary code for that same CT image. So if the machine's going to be able to read the scan, why would it want to convert it from its own language into one that we can understand? It just reads it direct. You can also think about, do you need to give contrast? Will the machine not just be able to use its binary coding in order to be able to read that? So there are possibilities that are coming. Obviously they're going to need to convert it back to an image that we can see that interfaces with us for human review at some point. But I think it's something to consider, certainly in terms of how that affects the workforce in the future. Other interesting things are really the machine singularity. So artificial intelligence, I've got a definition here, it's a machine that can learn and it can reprogram itself based on that learning and based on observable outcomes. So that's the definition of the singularity. However, in terms of whether that machine is going to be intelligent and can actually able to learn and to be able to have an intelligent response, how far away is that? Well, if you ask your Alexa at home, she'll tell you that humans get nervous about that, and so she's not going to discuss it. I asked, if you've got one, do try it. It's really quite interesting. My husband's a programmer, and he said to me, we must ask Alexa. So we did, and we were a bit disappointed, really, but yeah, a bit of a concern. There's something to think about, that one. So, how do we meet the challenge? Well, the challenge is that as a profession, we must be vigilant in understanding the need for change. We must be ready when the opportunity of change arrives. We must embrace that change and deliver it. Leadership is actually the key. How do we deal with change and pathway uncertainty in a rapidly developing future healthcare landscape? The answer is we must stay flexible. Small groups of determined experts professionally leading across innovative care delivery in concert. Imaging and oncology professionals are uniquely placed to cross the majority of patient pathways and join them up in yet-to-be-imagined ways. Most patients come across us at some point on their journey. This will require leadership skills. Specifically, the leaders of tomorrow will need to lead teams of experts, all of whom are individual specialists in what they do. It's potentially challenging, actually. What might it look like? Let's take a look at some leadership in action. Each person in that orchestra is an expert in their field. Each group of experts works in collaboration with the others. The conductor brings it all together, without which there would be a cacophony. Good analogy for us, isn't it, really? I like that one. I wanted to go on a bit longer, but actually I thought there might not be some fans in the room. Anyway, meeting the challenge, there are two things that we need to do. We need to develop a leadership culture, and we need a leadership strategy and a framework. That ensures that we're able to meet the challenges ahead, and we must equip the workforce with the skills to lead. And I think this is about how we're going to do it. So, as a profession, radiographers are uniquely placed to provide that leadership due to the multiple interaction points that we've already talked about with the patient along the care pathways. As a profession, we should seize the agenda. We must focus on the end goal, not just on our bit of the pathway. I will say that again, not just on our bit of the pathway, because we do this. We do this bit, they come to us, we do our bit, they go on their journey. We need to understand that journey, and that is the missing element, I think, for me. As a profession, again, we should seize the agenda. We need to make sure that we're able to seize that bit, that we have a collective responsibility, and actually we require visionaries. That's the important thing. Think about that when you're recruiting. So in terms of skill mix and culture, we must work with others to deliver the appropriate care, because we can't do this alone. Understanding the pathway and the roles other health professionals can play and what difference can we make alone and together is really important. So I've got a couple of examples, really, where we can make a difference. Radiographer-led discharge in ED. Radiographer reports a scan, or the AI reports a scan, or whatever, but you get that instant reporting, and then the patient, if it's negative, isn't returned to ED, and they go home. Therefore, you've saved time in ED, the savings drop out at the bottom, NHS improvement is happy, and so is the chief executive. The patient's happy because they haven't had to have an increased journey, and the radiographers are happy because they've got a job in Richmond. So everybody's happy. It's a win-win. This is currently happening in quite a few places. It's happening in the East Midlands in Leicester, and they're doing very well in that area. It's going well, I believe. That way we reduce the duplication, and it's really important. The second one is the cancer pathway. So cancer pathways are another example of devolved leadership. The diagnostic and therapy breast pathways are traditionally silos. We see our bit. The patient sees the whole thing, that whole journey. So many opportunities on that journey to cross-connect and to bring on other healthcare professionals at the right time in the pathway for the patient benefit. I recently challenged the breast consultant radiographers at Derby and also the new consultant oncological radiographer at Derby, now we've got one, to look at the breast pathway as a whole with a view to bettering it for patient benefit. The need to shorten the pathway and to signpost fast response teams to issues such as side effects. A holistic pathway is the aim, and we must make sure that that is focused around the individual patient for best patient experience. It also makes sure that we stop any difficulties before they become more advanced, and so therefore that the patient and also the service wins. So that's the breast care pathway. It's really complicated, isn't it? Just have a look at that for a moment. We must make sure that we simply have to lead the patients through it. We have to make sure that we're there, and we have to make sure that we can hand off to each other so that actually the patient is supported across that process. We must be empowered to do that. We must have permissions to do that, because we haven't got permissions culture, have we? We've got a protocol culture. We come and we do our protocol bit, and if we step off into the poppy fields, then usually we get our hands slapped. So we're going to need to think about how do we enable the practitioner to do the right thing. They need to understand the pathway, and they need to understand when things are going wrong, and they need to have the permission to be able to rectify that in short order in order to be able to get the patient back onto the right pathway. Situational leadership, a situational leadership culture. This is basically driven by experience, not by pay grade. It's the right person knowing what to do, when to act for direct patient benefit. We have to give them permission. So it's a different model of leadership. We still have a traditional command and control, not getting rid of the radiology managers that easily, but it's really important that it's not only a top-down, that you've also got this almost a matrix of leadership, so that you've got it that cuts through the organisation and that there is peer leadership available. It delivers that agile navigation of patients through the system we need in order to further develop individuals to be confident to undertake that navigational role. We need to make sure that we equip them with leadership skills. Not because of ideology, but rather that international research demonstrates that collective leadership is associated with high quality care for this reason. Collective or situational leadership is where staff at all levels act to improve care both within and across organisations, and in this case within and across departments and also across the pathway. So for me it's the Mummy Test Plus. That's essentially what this is. It's focusing on the patient, knowing the collective mission, understanding the goal, keeping that momentum going. Not patients pausing, waiting for long periods of time for something to happen. We need to drive that forward for them. We need to use those principles, not necessarily process. We have to focus on that. Lead by experts, not exclusively by managers. It's simply adding that additional layer of collective, situational leadership and applying it. See the need and do something about it. It's not rocket science. Do the best for your patient as you would for your mum. Take care to the next level. We need a strategy and a framework for leadership. So many opportunities. Here we are in the 21st century. Fantastic. Joined up strategy. So the matrix for the strategy for leadership includes the training establishments, the employers, professional body and individuals. There are some really good things happening out there, but it's a bit patchy. We must work in concert to develop a leadership matrix to deliver the leadership we require. So, these are the building blocks. And these are the guys that need to help us get that strategy in place. To all of us, really. So in terms of the professional body, and seeing as how we've got them sitting here, I think it's a good opportunity. There's a requirement to be able to articulate and promote a strategic plan for the delivery of a leadership culture and framework. The plan must be patient-focused. It must endorse the need to understand there's a lobbying requirement for funding, and also that there's an awareness of that requirement. Registration and regulation. We need to incorporate formal leadership in professional scope of practice. And we need to promote and support a network of and for leaders. This basically articulates and promotes the overarching need. A lot of this is already happening. I believe that the professional body are coming up with a strategy, and that might be near you soon, but we're just echoing that there's a requirement here. In terms of the educators, so ensure a patient-focused leadership training is embedded and incorporated into the core skill set for radiographers in both pre- and post-reg courses. There is a requirement to furnish the profession with the wherewithal to provide great leadership. We can utilise the apprenticeship levy for postgraduate training in leadership if it's not within the core skill set. Incorporating patient experience as a rationale for leadership should be the norm and become a focus of care delivery. There is currently some great work being done by teaching colleagues in terms of leadership training. However, this is not universal and requires a primary driver to be coordinated within a broader framework. Additionally, that leading must ensure that we lead within an interprofessional setting. Universities are ideally set up for that because they are excellent centres for interprofessional learning. And I think that interprofessional learning with regard to leadership is important because we're going to have to work with other health professionals quite closely. That's really, really important. We need to make sure that we incorporate the art of leading across boundaries and that we break down those boundaries in order to make sure that we deliver that great patient care that's required. What of the employers? We must develop patient-focused preceptorship programmes, try saying that after you've been to the AXFEM dinner, which must incorporate leadership training and skills, and we must promote freedom to act within the required parameters. We must identify that and nurture that emerging talent, really important. Appraisal is really important. Don't just pay lip service to it. Do it properly. Provision of a mentorship and coaching programme for emergent leaders together with development programmes are required within the workplace and embedded within the workplace. This to engender great patient-focused behaviours. With the advent of apprentice funding, employers are enabled to become commissioners for the workforce requirements. So a good example would be that, with the advent of MRI for therapy, in terms of planning and on treatment review, would we not be looking at a reconvergence of the profession in order for us to be able to make sure that our therapy colleagues have the appropriate MRI training that would be required for that, and that's within the core skill set? And similarly, would we not be making sure that we've got that leadership added in at the same time in terms of commissioning? So actually, we're going to be able to have an agile workforce because we're going to be able to commission around the workplace needs. In order to do that, we must act in concert, and so therefore it's important that we're cognizant of the STP landscape and we just don't go off into the poppy fields and do something at Derby because we think it's the right thing to do. We need to make sure that we're joined up, and that's really important. The individual. Well, we need to be patient-focused. We need to embrace leadership, not be frightened of it. We need to step up to lead. And we need to act as role models. Role model, really important. Role model the behaviours that are required. We must ensure that we're engaged with patients and sufficiently understand their pathways and our part in it to ensure good patient care. We must be prepared to step up to the challenge and embrace leadership. We must act as a role model, of course, and we must be able to deliver that compassionate patient care that our patients expect and that our patients deserve. So, we need to develop the leaders of tomorrow. And they're here in this room, and they're out there on the concourse. If not us, who? If not now, when? We are the vanguard. Thank you.